thank you, Respiratory Associates, first of all, for hosting this event. And a big shout out to our sponsor today, Radiometer America. Appreciate your involvement in making this event happen and giving out and providing the, the free CEU, sponsoring the free CEU. So thank you for that. I'd also like to welcome all participants that are here currently. Friday the 13th, exciting time, right? And it's a Friday afternoon and you're here. So thanks for being here. Let's learn something together. Now, the topic of this presentation is advanced ABG interpretations. And where this comes from is I teach college here at a local community college. And my students, they learn how to interpret blood gases. And so I give them a blood gas and I say, interpret that blood gas. And they say something like uncompensated respiratory alkalosis. Maybe fully compensated respiratory acidosis. And I say, perfect, what does that mean to you? And that's where it gets tricky. Because you see, they understand how to interpret it. They don't know what that interpretation means or what it tells them about what is happening with the patient at the time. And so it's very important that we understand how to interpret blood gases, but also what's going on. And so that's what today's presentation is going to be all about. Let's look at our objectives here. We are going to, one, identify acute ventilatory failure. Acute ventilatory failure, what does that mean? We're going to identify that. We're also going to identify acute alveolar hyperventilation. What does that mean? What type of blood gas does that look like? And then, of course, chronic ventilatory failure is also going to be another term that we're going to not only define, but also see what it looks like with arterial blood gases. From there, we're going to differentiate acute versus chronic arterial blood gas impairments. We've got to be able to tell the difference between acute and chronic. You have to, so that we don't, so that we make the proper clinical decisions for our patients. And then identify acute changes when they become superimposed on chronic ventilatory failure. This is going to be the keys and the objectives that hopefully you walk away with at the end of this. Now, before we jump into actually looking at any arterial blood gases, what we're going to do is we're going to make some definitions here. Okay, we're gonna define some terms. And the reason we're going to do this is if you're taking notes, be sure to write these down because I'm not going to write these out throughout the rest of this presentation. I'm going to shorthand them. Here's what it is. The first one is acute alveolar hyperventilation. I'm going to shorthand this as acute alveolar hyperventilation, AAH. Now, let's think about what this term says. Let's define this. You have a patient who is acutely hyperventilating at the alveolar level. Now, by definition, how this is going to appear is going to be a decreased carbon dioxide level, resulting in an increased alkalotic pH. That's acute alveolar hyperventilation. Keep that in mind. I'm going to refer to this as AAH from now on. Now, acute ventilatory failure. I'm going to refer to this as AVF. Now, acute ventilatory failure is defined by a person who is acutely failing to ventilate. Well, let's talk about what the word ventilate means here for just a second. In the realm of respiratory therapy, we know that there is a difference between a patient who is oxygenating versus ventilating. We know that ventilation and oxygenation are separate. Yes, they affect each other, but when looking at a blood gas, we will identify them as separate components. When we talk about ventilation, we're talking about the removal of CO2, the removal of carbon dioxide. So let's think about this. A person is acutely failing to remove carbon dioxide. This is going to cause a high CO2, resulting in a low acidotic pH. Now, the last one here is chronic ventilatory failure. This is going to be shorthanded to CVF, chronic ventilatory failure. Now, what we know is that we have chronic pulmonary diseases, and these chronic pulmonary diseases impair the gas exchange that normally happens over time. This gets tricky because chronic ventilatory failure is also going to be defined by a high CO2, which is just like we talked about up here with acute ventilatory failure. But because it is chronic, see, it's chronic, then we know that the CO2 is rising, it's high, it's elevated. We also know that our bicarb is going to be elevated. And the reason this is because it results in a normal pH. That's chronic ventilatory failure. This person, every single day, fails to effectively remove CO2 to what we define as a normal range. So they live with the high CO2, high bicarb, normal pH. This is the patient that we would refer to as the patient who presents with chronic hypercapnia, chronically a high CO2. Okay, so let's jump in here and take a look at some actual blood gases, because this is where it really gets interesting and it really becomes a lot of fun for me. Now we're going to start here from normal. Okay, this is normal. We all know our normal pH ranges. Remember, this is an advanced class, so we don't really have to put those on here. 735 to 740, we're right there. 35 to 45, we're right there. 22 to 26, and 80 to 100. This is a normal blood gas. So I'm just going to put this up here like this. This says normal blood gas. Now, what happens when this person gets sick, or maybe scared, or fearful, or anxious, or maybe they experience some type of accident where they experience a lot of pain? Then there's a good chance this person is going to start to hyperventilate. When that happens, you are going to see your CO2 go down. So let's just say the CO2 goes down to 28. Now, because this is happening from a state of normal, and this is an acute problem, your bicarb, remember, bicarb does not move fast. So it's going to stay the same. Bicarb remains at 24. So this drop in CO2 is actually going to cause your pH to become alkalotic, which is exactly what should happen, okay? Now, this is what we call acute alveolar hyperventilation. Now, if we went back to our basic understanding of arterial blood gas interpretations, we would say that this is an uncompensated respiratory alkalosis. Again, what does that tell us is happening at the patient level? Nothing. What does acute alveolar hyperventilation tell us? It tells us that our patient is hyperventilating. Okay, well, the question we now have to ask ourselves is why? Y'all know, if y'all follow me on anything, you know why greater than how. You know how to interpret that. The question is, why is it happening? Well, that's what we have to figure out. Remember, I said pain, anxiety, fear, all of those things can cause somebody to hyperventilate. But as respiratory therapists, what do you think is the biggest cause of somebody hyperventilating? Yep, you guessed it, hypoxemia. So you see where our PaO2 has decreased. Maybe this person is developing a pneumonia and they have a shunt now present and they are becoming hypoxemic. What does that do? Oh, that stimulates those peripheral chemoreceptors that operate off of the need for oxygen. It stimulates those. And they say, breathe faster, breathe deeper, increase minute ventilation. Why? Because we need more oxygen. And because of that, we see this alveolar hyperventilation that happens. Now, again, how are we going to fix it, right? If you had this patient, what would you consider fixing? We get sometimes caught up in going, oh, we got to fix this. But if we will always go back and ask ourselves, why is the hyperventilation happening? Because now we understand that that's what it is. Then we recognize that this person has been hyperventilating because of hypoxemia. If we can fix this, then we'll fix the acute alveolar hyperventilation. They won't have to hyperventilate anymore because they're no longer hypoxemic. Now, it doesn't mean there won't be another problem. Maybe they're still scared. Maybe they're still in pain and need some morphine, or anxious and need some Versed or Ativan or whatever it might be. But from the hypoxemia level, we fixed it, and this should resolve. Now, let's flip that in another direction. Let's look at what happens when this person does not immediately seek help. This is the person who's developing a pneumonia. They're hyperventilating. They don't feel good, but they're stubborn, and I'm not going to the doctor. I'm not going to the hospital. Then this disease process continues to worsen. The pneumonia becomes greater. And this person will eventually start to what we call hypoventilate. That means the CO2 is going to start to rise upwards. So CO2 goes up. Bicarb does what? It stays the same here. Remember, bicarb doesn't move fast. It's like a heavyweight boxer. It's slow to move, but it's powerful when it does. But it's slow to move. So the compensation doesn't happen for a while. Okay? CO2 moves quickly, more like a lightweight fighter. Really fast, doesn't carry a lot of power in its punch, right? But nonetheless, the CO2 goes up. Let's just say it goes up to 60. We're going to see that our pH is going to now go down to 7.21. And let's just say that our PaO2 is still over here. Let's say it's even worse now at 50, okay? Now, we would interpret this as an uncompensated respiratory acidosis. Okay, what does that mean? Uncompensated respiratory acidosis means you have a respiratory problem causing an acidosis. You with me? Doesn't it make sense that we could just say that this patient and this blood gas is acute ventilatory failure? This person is acutely failing to get rid of CO2, causing an acidotic pH. Guess what else is happening? The hypoventilation that is now present is causing the hypoxemia to worsen. So you see now where our O2 is even less. What are we going to fix now? You want to put this person on oxygen? Absolutely not, because we know that in this situation, putting this person and fixing their PaO2 will not aid them with the removal of the CO2. So here we have to start by helping them get rid of the CO2. This would be an indication where we need to implement some type of mechanical ventilation. Get the CO2 back down, adequately ventilate the patient, right? This is acute ventilatory failure. So now we need to help them adequately ventilate. And when we do so, we know that our oxygenation might improve. Because remember, we do know that hypoxemia can be caused by hypoventilation. That's what's happening here. So adequately ventilate, seeing improvement in your O2, we still may have to add some FiO2 and add some PEEP, but the focus is now on helping the patient get rid of the CO2. Why? Because they are in acute ventilatory failure. How many times do you see this on a chart? You see this, you see acute respiratory failure. Well, I need more information. When you tell me the patient's in acute respiratory failure, I immediately say, okay, what type of respiratory failure? Because we recognize there's two different types. There's type 1 and type 2. There's hypoxemic respiratory failure, and there is hypercapnic respiratory failure. Hypercapnic respiratory failure is another term for acute ventilatory failure evidenced by your arterial blood gas. High CO2 causing a low pH. That's super important. It's super important to recognize that this pH is acidotic, okay? Because what we're going to see here right now is that we can also have this blood gas, okay? So pH, PCO2, bicarb, PaO2. Let's break this down. Normal pH, okay? High CO2, high bicarb, low PaO2. Now, when we look at this, sometimes, especially if there's any, I know there's some students in here because I saw your names, you want to maybe approach this and go, oh, I'm worried about this CO2 because it's high. You have got to recognize this is not a problem. Like, we can't call this normal because it's not a normal blood gas. What we would interpret this as is compensated respiratory acidosis with mild hypoxemia. Perfect. What does that mean? What it means is that the person lives at a state of chronic hypercapnia, a state of elevated CO2. But because they live there and because the bicarb has elevated, we see we have a normal pH. We're not worried about this CO2 because this person lives in a state of chronic ventilatory failure. That's where they live. This is their normal. This person right here is a COPDer getting on a plane to go to Vegas right now, or Hawaii, or wherever they're going. This person isn't in need of any type of intervention because why? They live at this chronic state. Now, this is where it gets tricky because what we know is that this person who, let's just say this person has COPD, we know that they can become acutely ill. They can also experience acute impairments on top of their state of chronic ventilatory failure. Guess what though? It looks identical to what we just talked about. Here's what happens. Because this is going to be an acute process, let's just say this person becomes fearful, in pain, anxious, whatever it is. But for us today, we're going to say they become more hypoxemic than normal. So let's say their PaO2 goes down to 45. Well, guess what? The same thing that happened to the patient from a normal baseline where they began to hyperventilate in response to the hypoxemia, this person is going to do the same thing. And you're going to see where their CO2 goes down. Let's just say it goes down to 48. So it goes down to 48. Now, because this is an acute problem happening here, bicarb, once again, is going to remain normal. Anytime CO2 goes down and bicarb remains normal, your pH will go up. This is the exact scenario and the definition that we gave to acute alveolar hyperventilation. That's exactly what this is, acute alveolar hyperventilation, except this is now superimposed on top of this person's normal of chronic ventilatory failure. So you would look at this and go, oh, this person is hyperventilating, but they're hyperventilating from a state of chronic ventilatory failure. So acute alveolar hyperventilation superimposed on chronic ventilatory failure. How do we know it's superimposed on chronic ventilatory failure? The bicarb tells us. When you have a patient that presents with an elevated bicarb, pursed lip breathing, barrel chest, digital clubbing, it screams COPD, this is their baseline bicarb. So how do we know it's acute alveolar hyperventilation then, Joe? So this says chronic. How do we know there's an acute problem? Because the pH is no longer normal. It's that sudden change in the CO2 that is causing that alkalosis. Now, there's something special about this one right here. This, to me, in my opinion, is one of the hardest blood gases to recognize. I'll tell you why here in just a second, okay? Again, though, before we go there, how are we going to fix this patient? We fix the level of hypoxemia. Bring them back up to their normal. They won't have to hyperventilate anymore. So that's the game here. You have to recognize, why is this person hyperventilating? Because of the hypoxemia. Now, it could also be that they're just early into the process of an acute exacerbation. So that's 100% true. It could 1000% be that. This is maybe an impending exacerbation that's coming. But as we see right now, all we know is, even though this looks elevated, that's where it gets tricky. You look at this, you go, oh, elevated CO2. That's weird. You can't think like that, because you recognize, wait a second, we're alkalotic because we are less than our normal. So even though it's elevated, it's not for this patient. Okay, so keep that in mind when you see an alkalotic pH superimposed on an elevated bicarb. There's a good chance this is a chronic patient who is hyperventilating. Okay. Now, again, just like we did on the other slide, there can be times where this patient progresses to a state of acute ventilatory failure, where they are no longer able to effectively remove their CO2 to sustain this normal pH. When that happens, we will see CO2 elevates. Now again, bicarb stays normal. Now you go, wait a second, that's not a normal bicarb. It is for this patient because this is where they live. So bicarb remains constant. What does that do to pH? Anytime CO2 goes up, you know that your pH is going down. Now we have an acidotic pH. Well, wait. I thought they always had a high CO2. They do, but not that high. How do I know it's not always that high, Joe? Because they're acidotic. Now, of course, your PaO2, you know, it's going to be down here, whatever it is. They're going to be hypoxemic because they're hypoventilating. That's one of the causes of hypoxemia. So PaO2 is down here. We'll address that after we return this patient to a normal baseline. High CO2, acidotic pH. What do we call this? Acute ventilatory failure. Oh, but don't stop right there, Joe, right? Don't stop there. We got to remember that this is superimposed on chronic ventilatory failure. Now, this is extremely important right here. The fact that we know that this is an acute ventilatory failure superimposed on chronic ventilatory failure is why it is super important to recognize that we do not want to normalize this patient's CO2. How many times, respiratory therapists, raise your hands, put it in the chat, something. How many times have you seen a COPDer come in with a CO2 of 80 and 8 hours later, we got a CO2 of 40? Yeah, right? We said, well, we've got to normalize CO2. We got to get 35 to 45. No, we don't. We have to get back to what? Their normal. How do I know what their normal is, Joe? When your pH is back between 735 and 739. That's where they live. And that's their normal. So recognize acute ventilatory failure superimposed just tells you on chronic vent failure, it just tells you that, hey, the CO2 right here is higher than their normal, and we need to help them get it down. Non-invasive, probably a great candidate for non-invasive ventilation right here. 30 to 45 minutes, if you can get that CO2 back down to 60, this person doesn't have to be intubated. The need for escalation of care to mechanical ventilation, we can avoid that with our non-invasive strategies if we can make it happen relatively quickly, okay? Now, we've talked about 6 different examples, really 5 because the normal one doesn't really count, but I'm gonna keep it in the picture because I wanna put all 6 of these together and let's look at what we're looking at here. Because like I said, a lot of times when we start talking about the superimposed part, superimposed, acute ventilatory failure, acute alveolar hyperventilation, superimposed, like why do we have to make it so complicated? Well, it's because it is what it is. You got a problem with 2 problems happening. You got an acute problem and a chronic problem. But let's help make this make sense, okay? So we're gonna tie these new terms kind of into the older terms, okay? So we're gonna start here and I'm gonna move this away. Remember I told you this is the trickiest one right here, right? So we're gonna finish on that one, okay? So here we have a normal bicarb, a low CO2, and an alkalotic pH. Remember what we called this? Acute alveolar hyperventilation. Perfect. That's what we called it. Why? Because this is our normal starting point. CO2 went down, pH went up. Now, if the superimposed challenges you, then this is the way I kind of like to talk about this, but I will caution you, don't ever say this to a physician, okay? Don't ever say this to another respiratory therapist. In your mind, what you know is you can go, this is acute alveolar hyperventilation superimposed on normal. That's all it is. It's just saying this person lives at a normal state. So we just call it acute alveolar hyperventilation. We don't have to say superimposed on normal because it's assumed that it's on normal unless we indicate that it's on top of chronic ventilatory failure. Now, when we look at this from our standard ABG interpretations, again, we call this uncompensated respiratory alkalosis. The word respiratory in there tells you it's a problem with the CO2. Perfect, got it. Let's slide over here. CO2 goes up, pH goes down. bicarb stays the same. This is acute ventilatory failure superimposed on normal, right? We don't have to say that, but just to make a point here. This is their normal. So we just say acute ventilatory failure. We need to help this person get rid of their CO2. Standard interpretation, uncompensated respiratory acidosis. This is key here. Okay, uncompensated respiratory acidosis. What does that tell us? Nothing. What does acute ventilatory failure tell us? Everything. Let's go down here to this patient. Okay, we see an elevated bicarb. We see an elevated CO2. We see a decreased pH. This elevated bicarb tells us, and of course, you got to put in some patient assessment skills into this, because you have to be able to get to the point that, oh, there is an underlying chronic pulmonary disorder present. Once you have those clues, those signs and symptoms, that patient history, pack years, extremely valuable in this. If this is a patient with a pack year of 80 pack years, this is a superimposed blood gas. This is a state of chronic ventilatory failure. But because we are acidotic, we know this is acute ventilatory failure superimposed on chronic ventilatory failure. Well, now let's think about this for just a second. If we interpret this traditionally, we would say partially compensated respiratory acidosis, which gives you the illusion that there is compensation in the works because it's partially compensating. Or maybe you just called it compensating respiratory acidosis, but not really. There's really not any compensation that has begun yet, because look, it's an acute problem. So our bicarb has not begun to respond to that rise in CO2 to 80. So you can't justify this as a partially compensated respiratory acidosis. That's probably right in the test, but we know better. We know we need to help this person get rid of that CO2 because we have an acute problem superimposed on a chronic problem. So this is interesting. So keep that in mind. Now over here, we see high CO2, we see elevated bicarb, we see normal pH. Well, okay, this is fully compensated respiratory acidosis. This person lives here, again, chronic ventilatory failure. This is their normal. This person is probably does not need your intervention in terms of trying to help them get rid of this CO2. This is where they live. So don't mess with that. If we interpret this, again, fully compensated respiratory acidosis. Watch what's about to happen. Watch this. Who's paying attention here? This uncompensated respiratory alkalosis. You see what the trend is here? Uncompensated respiratory acidosis. Partially compensated respiratory acidosis. Fully compensated respiratory acidosis. You see, where anytime you use the word respiratory into your interpretation, you need to ask yourself, is this acute alveolar hyperventilation, chronic vent failure, acute vent failure? Maybe it's acute vent failure superimposed on chronic vent failure. Anytime there's a respiratory disturbance in your interpretation, these advanced terms are applicable. Watch this one. Why is this the hardest one? Why'd I put an asterisk by it? Watch what happens. Interpret this blood gas. We got a high CO2, got a high pH, got a high bicarb. Guess what that interprets as? Partially compensated metabolic alkalosis. So we got a metabolic problem here. You gonna walk away from this blood gas and not do anything for this patient? I don't think so. This is a respiratory disturbance superimposed on chronic vent failure, even though it traditionally interprets into a metabolic problem. That's why that asterisk is there. It's the hardest one to recognize. Okay, so this is AAH superimposed on chronic vent failure. We know that. That's what it is. This is a chronic patient who is hyperventilating 100%. Okay, so I think it's interesting when you look at all these together. This one right here presents as a metabolic problem, even though we know it's not, right? Because we're smarter than that. We can recognize these acute changes from our chronic pulmonary patients. Now, that right there satisfies the objectives. Okay, so if you're paying attention and you're asking, is he going to meet the objectives? I just did. Okay, but I'm going to give you some bonus material here, and we're going to go in and we're going to talk about metabolic acidosis. So let's look at this here real quick. This is the same blood gas. Like, why you got it up there twice? Because it can be different. This blood gas looks identical, but there can be two different causes of this blood gas. And the reason I'm going into this is because I do not want you to make the same mistakes that I made for the good portion of the first part of my career, which is every single time I had somebody that presented with a low pH and a low bicarb, and maybe even a low CO2. This is partially compensated metabolic acidosis. Why is it partially compensated? Because the CO2 is down. Okay, CO2 down is trying to bring the pH up, but it hasn't yet. This is a metabolic problem, truly, metabolic acidosis. I can't tell you how many years I went around saying, hey, we need to give this person bicarb. We need to give this person bicarb, right? This is what we learn. If you don't have enough bicarb and you're acidotic, what do we need to do? Give them more bicarb. That's not correct. Okay, don't learn from me, please. Don't go around saying that, because you will get checked one day like I did. Somebody finally pulled me to the side and said, you need to understand the concept here. I'm about to give you that concept right now. We're going to come back to the screen in just a second, okay? But for right now, what is this, right? Well, this is how we're going to illustrate the anion gap. And that's what I want you to take away from this. Anytime you have a metabolic acidosis present, you have got to ask yourself, well, I need to assess the anion gap. Well, what is the anion gap? Basically, it revolves around this concept of the law of electroneutrality, which means you have your major cations. I'm just going to write it like this. And you have your major anions, okay? These boxes, based off of neutrality, must remain equal. In other words, this box cannot and will not be bigger than this box. Now, when we talk about major cations, sodium is the major player in the game. That's the one that is part of this formula. Now, potassium used to be a part of this formula and probably still is, but for practicality's sakes, it's basically been taken out because it's so small, it doesn't really affect the end value we get. Okay, so we're just going to leave this as sodium. Now, we know that the balance of sodium must equal the balance of our anions. Chief one here is chloride. Oh, look what's coming back in this story. And bicarb. And then guess what? There's some unmeasured acids that exist. And those unmeasured acids are called non-volatile acids. So I'm just going to call this box right here non-volatile acids. The box is very, very small because we typically don't have a whole lot of them, okay? So relatively small when it comes to this. The problem is because they're unmeasured, here's how you figure out what the size of that is. If we know that this box is equal to this box, then all we simply have to do is say that sodium minus chloride and bicarb, put these two together, will equal that box. And that box is called the anion gap. There's two different types of metabolic acidoses. There's an increased anion gap acidosis, and there's a normal anion gap acidosis. Here's what it looks like. Bear with me, I'll make this make sense. Now, this is normal, okay? So remember, this box is going to equal this box. Remember, this was sodium plus chloride plus bicarb. And these are non-volatile acids here. Now, we didn't talk about numbers, so let's put some numbers in here. Let's just say we know normal sodium is 135 to 145. So we'll just say that our sodium is 140. Normal chloride is 95 to 96 to 106, depending on what values and what text you're looking for. Let's just say it's 105. And let's just say our normal bicarb here is 25. Just keep numbers simple here, right? Well, 105 plus 25 is 130. When we subtract that from 140, we get 140 minus 130. That belongs here in this box. That's an anion gap of 10. Now, Egan says that your critical anion gap level is greater than 14. Okay, so greater than 14. Other texts, slightly different. Anytime you see an anion gap in the teens or in the high teens, it's elevated. Okay, and we're going to make this make sense here real quick. Now, pretend like this box is not here. And we're just going to go, okay, well, what happens when bicarb decreases? So let's just say bicarb goes down to 12. Well, bicarb has an inverse relationship with chloride. So if bicarb goes down in terms of actually depleted from the body, then chloride goes up. So what we'll see here is that our chloride will rise. So this is bicarb. This is chloride. See how the box went up here? That's an increase in our chloride. Why? Because we've lost bicarb from our body. So let's just say that chloride goes up to 118. Okay, well, 118 plus 12 is 130. If our sodium stays normal at 140, 140 minus 130, our anion gap here is still 10. But look at this. We have a loss of bicarb. Is this going to cause a metabolic acidosis? 100% it is. It's going to cause a metabolic acidosis. But the thing is that it's not an elevated anion gap metabolic acidosis. This person has actually lost their bicarb supply. It has been depleted from the body. This would be associated with things like diarrhea, prolonged retractable diarrhea. The bicarb gets depleted, exits the body. There is no supply. Chloride rises, but our anion gap stays the same at 10. This person right here, you want to give bicarb to. This person needs bicarb. It will help this person. Of course, you got to stop the diarrhea. But giving bicarb is indicated here. Okay. Well, let's look over here. Look at this third one here. Remember, chloride started out at 105. It's going to stay 105. Bicarb is going to decrease. Let's just say it goes to 12 because that's what the number was in the example. It goes to 12. Now you may be thinking to yourself, well, wait a second, Joe, how come the chloride didn't rise in this situation? That's a great question. The answer is, look at the non-volatile acids box. Look at the anion gap. Let's calculate it. 105 plus 12, 117. 140 minus 117 is 23. Remember I told you greater than 14 was a problem? This is an increased anion gap right here. Now what this means is that there is an increased amount of non-volatile acids. Non-volatile acids are things like lactic acid, ketoacidosis, sulfuric acid related to like renal failure. See, those patients also will present with a metabolic acidosis because their bicarb is decreased to 12. Okay, Joe, so help me make this sense. How come the chloride didn't rise? Because the fact is that while the bicarb looks decreased, it hasn't left the body. It's just occupied. What's it occupied with? The increase in these non-volatile acids. So the lactic acidosis from your septic patient, your DKA patient, your renal failure patient. This increase in non-volatile acids are just occupying what used to be here. So chloride remains normal. Bicarb goes down, increased anion gap goes up. This person will not benefit from the administration of bicarb. It's like putting a Band-Aid on a tib fib fracture. Okay, you fixed the problem? No, we did not. If you take a DKA patient and give them bicarb, guess what? They're still in DKA. Take a patient who is hypoxic and has an increase in lactic acid. You give them bicarb, they're still hypoxic. So you have to fix the problems with these patients. When you have an increased anion gap, why? What is the increased acid? Lactic acid? Let's focus on tissue perfusion, blood pressure, oxygenation, fluid resuscitation. Or what about DKA, right? Let's give them some insulin. Let's fix the problem. What about renal failure? Let's get them to dialysis, right? Those are going to be the fixes to this increased anion gap that's causing a metabolic acidosis. So I bring you back to this screen right here, which is where we started this metabolic acidosis. Let's say that this person has an anion gap of 10. This person has an anion gap of 23. You now see where you have two different stories here. From here down, they look identical. But this one piece of the puzzle right here, the anion gap, gives us more information. This person here, give bicarb. Give bicarb. This person here, bicarb is not the answer. Fix the problem. What's causing the increased anion gap? That's your solution to this patient here. Okay, let's summarize this up. We'll wrap it up and take any questions. When we are looking at arterial blood gases, you must be able to identify the difference between acute and chronic situations. Remember, your pH will be the indicator. An abnormal pH is an acute problem. The indication is either acute alveolar hyperventilation or perhaps acute ventilatory failure. Either way, the pH will not be normal. If it is chronic ventilatory failure, you will see a normal pH, but you also have an increased CO2. And the reason that pH is normal is because you have an elevated bicarb. So your elevated bicarb here tells you this is chronic. Now, when you have an elevated bicarb with an abnormal pH, whether it's high or low, then now we know we have an acute problem superimposed on a chronic problem. Fix the problem. It's still just the same as fixing it. Hyperventilation, why are they hyperventilating? Acute vent failure, fix the acute vent failure. And then always remember, anytime you see a metabolic acidosis, you must assess the anion gap. That is going to be the piece of the puzzle that helps you solve and help be a part of the care team to actually come up with a solution for this patient. All of this information comes out of, in part, Egan's, but also comes out of Desjardins' Clinical Manifestations and Assessment of Respiratory Disease. These are the two books that this information comes out of if you're interested in those references. If you're interested in reaching out to me or contacting or continuing this conversation further beyond the little bit of time we have left here coming up, here's how you find me. I'm on all the socials, Instagram, TikTok at Respiratory Coach, Twitter at Coach RT. You can always send me an email at respiratorycoach@gmail.com. If you like this presentation and you're like, I think I want to watch that again, even after you get your CEU, it will be posted to my YouTube channel, which is also at Respiratory Coach. You'll be able to watch this again very, very soon. And then if you would, send me a text, 817-968-7035. Join my texting platform where I send out occasional inspirational, informational, motivational, educational material just to further connect us, this field of respiratory therapy, in moving towards the future and taking this to a dynamic level.